910, Big 550, KTRS. Welcome in the audience watching on KPLR 11.2. We're going to take a break from the rough and tumble politics because I'm under a doctor's orders to only talk about it certain amounts of time during the week. And I need to go out and look at the brighter side of life, to take positive steps and to be inspired. And that's why our next guest is going to be here. Rochelle Hobson, you are a hospice nurse, right? Is that correct? You're with Celtic Hospice here in town. And we met on Friday. In terms of full disclosure, well, I'm going to start doing some commercials for Celtic Hospice. And we met to sort of go over what Celtic Hospice was and so on and so forth. And when they came to me and they asked me if I wanted to do a commercial for a hospice center, I was like, boy, I know just enough about hospice to be dangerous. And so when we met and we were talking on Friday, and I was so engrossed by our conversation, we wanted to have you to come on the show to sort of tell your side of the story, because it's one in which people hear the word hospice, but they don't really understand what it means. Would you agree with that?
I would absolutely agree with that.
Yeah.
Absolutely.
If you can talk a little closer into the microphone, we want everybody to hear you. Okay, so your story. How did you get to become a hospice nurse?
So when I started my nursing career, of course, looking for jobs, there was an offering in oncology, and they had a hospice unit, and I did not necessarily want to do that. I always thought I'd be a surgical nurse, and so I went and took this position, and shortly after coming off of orientation, I had a patient who died, and it was one of those experiences. I was in my 20s and hadn't really experienced anything like that, and I remember thinking this family is counting on me. They're waiting on me to tell them what to expect next. I had to console them. And I remember thinking to myself, it was something that if I was going to do this for a career, I needed to get it right.
Right.
And so I went and started working with the 2 hospice units that we had, and just absolutely fell in love with the relationships that I was able to build with people, and just listening to their story, it helped me become a better person. And I've always fallen back to hospice. I just love it.
Yeah. Hospice, when people say hospice, I think they conjure up, you've got 3 days to live, go to a room in a nice, comfortable bed, and have your family come from around the country and say your goodbye. But hospice isn't like that at all.
It is not. I think that is one of the biggest misconceptions about hospice, is that it's just about end-of-life care. We try to take the approach from hospice, especially here at Celtic, that it's about quality of life as opposed to just end of life. And so when we get patients at the end, it's unfortunate, because I think it helps to further that stereotype that hospice is just end of life. But the reality is that we can do so much more when we have patients and we get them early. When we have someone who we know has a life-limiting illness, then we're able to go in to help the family, to teach them how to do care. I mean, we're asking people to do stuff that nurses do. And so when you can get them the support that they need and everything in terms of resources and medical equipment to make their life easier, there's so much that we can do. And then we can also do things with life wishes. I had shared with you on Friday a story of a young lady who has a life-limiting illness, and one of her wishes was to be able to swim with the dolphins. And so our agency, through Celtic and the social worker, we were able to partner and get this lady down to Florida to swim with the dolphins. And those are the types of things that we can do in hospice when we have time.
Okay, you said if you get hospice earlier, again, people think, oh my goodness, if I start accepting hospice earlier, that means I might die sooner. Explain that. Why hospice earlier is better?
So there have been all kinds of studies that actually show when we can manage a patient's symptoms at home, they're less likely to end up back in the hospital. And we're also able to manage their symptoms, and so it's less stress. So we're doing things like decreasing the number of medications that they're taking unnecessarily. And so we're also working to give them quality. Again, I always go back to quality, because when you can have a person surrounded by their family and different care and intense care. So one of the things that you think about with treatment is you think about aggressive treatment, and everybody wants everything. But what we like to do is think of it more like aggressive symptom management, because we're doing all those things at home. So then again, a patient who has heart failure, who's in and out of the hospital, once they go home, who's there to monitor them? There's no one usually. And so when hospice comes in, we're able to monitor their medications, monitor their weight, make sure that they are being taken care of and managing their symptoms, keeping them out of the hospital, and thus giving them quality and more time. So they live longer on hospice.
You told me they live longer on hospice, which is interesting. You told me that some people who call you up, and you're nurses, because you now run all of the nurses. You're the head nurse for Celtic Hospital or Celtic Hospice. You told me on Friday that some people start off with hospice and then get so much better that they no longer need hospice.
That is true.
Explain that.
So we oftentimes, again, it goes back to symptom management. So through hospice, we're able to manage their symptoms, again, giving them aggressive care. And so while we're doing that, we find that, on hospice, we can do physical therapy, which is something a lot of people don't know. So when we bring a patient in and they're weak and we're trying to get them stronger, we can bring in physical therapy and occupational therapy to assist them. We bring in nursing care. We teach the family how to transfer the patient. We're monitoring their symptoms. There's a doctor reviewing all of their medications every 2 weeks and a nurse going in at least 2 to 3 times a week. And when that happens, all of a sudden you start to see a patient who their kidneys start working better. Their symptoms are resolved. They're getting stronger. They're able to transfer. And as they get stronger and able to transfer, then we're able to graduate them per se or discharge them from hospice. And that's one of the joys of the job, is that you have the opportunity to make such an impact, not just with end of life. Yeah,
oftentimes people say, I want to go die at home, right? But I would think being at home, getting out of the hospital, I've spent some time in a hospital. I've been sick. I've been laid up for a week or whatever in a hospital. No disrespect to the hospital, but that's not where healthy people go. And so you're not in a very good mood around the hospital. I would think if you could be treated at home, your just whole mental side wakes up.
It does. I can give you an example of a story where we had a lady who was in the hospital, and of course, in the hospital, it's aggressive treatment. So we're looking at things like IV nutrition, and this individual wanted to come home on hospice, but wanted to continue that IV nutrition because the mindset is, we're going to do all these active treatments. Once we got her home, she had a pond out in the back, and she said, if I take this IV off, what's going to happen? And the nurse said, well, can you eat some Jell-O? And she said, yeah. She goes, well, take the IV off and go sit at the pond. And this is a lady who they told us wouldn't be with us for more than a week. Right. And a month later, she was still with us because, again, she was able to go out, sit at the pond, have her grandchildren, and she wasn't hooked up to an IV. So there's so much that, when you get people home, they have better quality.
Rochelle Hobson from Celtic Hospice, you're talking about physical therapists, doctors, nurses coming to your home. This must cost a fortune.
Actually, it costs nothing. So that is a big question that we get a lot of times. And so with Medicare in 1983 said, this is a valuable service. We believe in it. And so it is covered 100% under the Medicare benefit. So there is no charge to the patient for anything that patient is admitted for. If they're admitted for heart failure, then we're going to cover all of those medications as well as anything they would need for comfort. A lot of times you have patients who have to meet certain requirements for oxygen. With hospice, we are able to provide oxygen and other comfort measures free of charge to the patient, and that includes their nurse, their therapy.
I would think it's cheaper to treat them at home than it is in a hospital.
Absolutely, it is. And you see more and more hospitals urging and supporting hospice and palliative care because we can keep patients home. And the new guidelines are saying we shouldn't be readmitting patients within 30 days of a discharge. And one of the ways that we can prevent those readmissions is through hospice.
Yeah. But there are some weekends where, 3-4 people you've come close to die.
Yes.
How do you deal with that?
I think the most important thing when we do have patients die, and thank you for using the word die, because a lot of times people are afraid of those words and we hear cover up. And I think that we have to be honest. When people die, we have to be supportive, not only of our staff, but also of the families that have been in our care. And so we do offer a year of bereavement to our patients' families. And it is one of those services, that I consider our lean in and an opportunity for us to reach out to the family and support them through that year. And you'll hear a lot of times families say, I thought I could do this on my own, and they can't. And so then they're able to reach out to us.
But how does the nurse deal with, these people you've come close to, whether it's a week or 6 months or 3 months or whatever, you get to be close to Mrs. Jones or Mr. Smith. And then, that they're at the end of their life. How does the nurse deal with that?
I think especially I can speak for myself and a lot of people on our team, you reach that relationship, and the comfort that we get is knowing that we helped, number one, the family come to terms with something that is unbearable, and then it's the reward of the thank you. I think that there's that little place that you put each patient and you say, this person loved chocolate, and you walk away and you smile knowing that, you helped them get where they needed to go, and that you made a difference when you walk away from a house that you've been in for 6 months or a week, and you had that patient comfortable and they were able to transition in peace, and you hug that family, that you did a good job.
On Friday, you were telling me about people coming to grips with the news and how you and the nurses and hospice sort of help that process along. Explain that.
So, when someone is given a terminal diagnosis, we're able to, help them understand how predictable this is and help them understand the symptoms as they go. I always like to say that there shouldn't be a surprise. When you're dealing with an illness, there shouldn't be any question that you can't ask. There shouldn't be any symptom that you've not learned about and anything that we can't help you to manage. And so we do talk to the family and we give them encouragement. I think that's the biggest thing. It's scary, to have to manage something like this at home. But if we can encourage them and be right by their side, a lot of times when we're given first dose of medications, we're the ones giving it so that family understands and we're educating them. There's a lot of education that goes into hospice.
Rochelle Hobson of Celtic Hospice, tell me about the was it the convention you were at where you walked into that movie at the end of the day?
Yeah, so this is actually really exciting and really, really interesting. In April, I was at the National Hospice and Palliative Care Association convention, and they had a movie called Road to Hope, and honestly didn't really know what I was walking into, thought it was just something about hospice. And after watching it, what we learned is that there are 53 million children.
It was a documentary.
It was a documentary about sub-Saharan Africa and the conditions in which they provide palliative care. And so one of the things that they mentioned was that there are 53 million orphans. These children are orphaned because they are actual caregivers. So, when you try to imagine what it takes for us as adults to care for a dying parent, imagine that you're 4 years old and you're putting your parent on and off of a bedpan, or you're there watching them die and then, going through those processes. And so there is an opportunity to partner with the Global Partners in Care through this National Hospice and Palliative Care organization. And I looked at my vice president of nursing at the time and said, oh my gosh, we have to do something. We have to help. And she said, absolutely. And so recently in September, we signed a partnership with Malawi Africa, the Palliative Care Support Trust, to support them and to help fundraise, not only to give financial support to them, but also educational resources, because we take for granted here in the U.S. that we drive to our patients and they're walking to their patients. Mm-hmm. And so we're going to be able to raise money to help support nursing care, to provide medications. We have medications. We have those drugs readily available to make sure our patients are comfortable. And
there are people coming from Africa to St. Louis, too, to learn, right?
Absolutely. So in February, Dr. Cornelius Hua will be here from Malawi, Africa, and we're going to have him come and tell his story. And then we'll also be having their nursing team come here to the U.S. to learn how do we take care of patients and what are the best practices and what are we doing now that's relevant.
There are families out there. There are seniors out there. There's all sorts of age groups, because you're seeing hospice isn't just for the elderly. It's anyone who's been given a diagnosis in which it's going to be difficult to deal with. What's the one thing you want them to know about hospice?
Is that at hospice, it's not just end of life, and that we have so many opportunities to help you so that you can use your resources in the right way, financially, to have the support, to get the caregivers that you need. I want you to know that hospice is not just end of life. It is quality of life, and we can make a difference.
Yeah, and Celtic Hospice and Healthcare, some people, as we said, go from hospice to home health care. So you transition them out of hospice into home health care. So they still need a little bit of help, but they can still certainly stay in their own home.
Absolutely.
Yeah. Boy, you're a special lady.
Thank you. I love this.
Thank goodness there are people like you out there, because there is a special place in heaven for you. Rochelle Hobson, Hospice Operations Manager with Celtic Hospice and Healthcare. And you'll come back from time to time and give us inspirational messages?
Absolutely. Would love to.
Rochelle, thanks for coming in.
Thank you.
924 here, Big 550.